All right, so please, we are starting. Okay, let's fasten our seatbelt. Okay, all right. So what is asthma? So asthma is a chronic respiratory disease characterized by chronic airway inflammation. Sorry, okay. It is a chronic respiratory disease characterized by chronic airway inflammation, mucus production, airway obstruction, and hyper-responsiveness of the airway or hyper-responsive airways. Okay, very good. So on my screen, you see an image on the right side. Okay, there's a normal lung and there's an asthmatic lung. Okay, please, those I have made what do you call it, co-host try and then be muting them for me. Okay, all right. Please, if someone unmute the microphone, try and be muting them for me. Okay, all right. And those who are the co-hosts, Madam Nanekia, Madam Mavis, Miss Shelley, or yeah, please be doing that work for me. Okay, all right. Thank you. So on the screen, we see a normal lung and then an asthmatic lung. Let's focus on asthmatic lung. What are we seeing? Please, we are zooming on. Okay, we are zooming into it. So let's focus. What are we seeing in the asthmatic lung? We see muscle tightness, swollen lining, and then a mucus or excessive mucus, okay, or excess mucus. Muscle tightness, swollen lining, and then excess mucus. Okay. So what? These are what we are seeing in a patient with asthma. Okay, now let's deal with the pathophysiology. What is occurring in asthma? Okay, when we see a patient is having asthma, what is really occurring? So asthma is a chronic respiratory characterized by one, a chronic airway inflammation. What or how does the inflammation occur? We all know that asthma, for you to get asthma is common, okay? For you to get asthma or for asthma to be triggered, it is usually it comes as a result of what? Of allergens, okay? Usually allergens, or there must be a trigger. Let's settle that fact that there must be a trigger. Okay, something must trigger
What
the
are you
attack.
doing?
Okay, something must trigger the asthma. Okay, so when you are exposed to allergen, are you following? When you are exposed to allergen, and then the allergen causes inflammations in the airway, are we paying attention? So asthma, it is countered by first chronic airway inflammation. Okay, so you will be exposed to the allergies or the allergens. Okay, or whatever will cause the trigger. Now, when you are exposed to the trigger or the allergens, this trigger will begin to cause inflammations in the airway. Okay, now when they cause the inflammations in the airway, they lead to mucus production. Now, how does the mucus production occur? Due to inflammation.
Which rice? That one I.
Okay. Oh, please, can we mute up? All right. So you'll be exposed to the allergen, okay, or you'll be exposed to what? To maybe an allergy that will trigger the inflammation, okay. So now, when you are exposed to any allergen and then you are having what do you call it, a chronic or an airway inflammation, there will be a release of inflammatory mediators or chemicals due to the inflammation. This inflammation begins to act on the airways, or they begin to have an impact on the airways. Then they begin to cause what? Mucus production and bronchoconstrictions. Okay, very good. So now, when you are exposed to the allergy or the allergens, they causes inflammation. The inflammation is due to the fact that there's release of inflammatory mediators. The mediators will begin to act on the smooth muscles in the mucosal lining of the airway. Okay, focus is on the smooth muscles. Okay, the airway are made up of smooth muscles. Okay, that helps to relax and contract. But the moment there's an inflammation, the smooth muscle begins to constrict excessively, okay, in an abnormal manner. So the smooth muscles in your airway begin to constrict, leading to bronchoconstriction. Okay, that is why the airway begins to obstruct. Okay, then this same inflammation will attack what we call the goblet cells. The goblet cells and they are epithelial cells. Okay, they are located in even the GI system, around your eye, and then the respiratory system. Okay, the airways, they are there. Now, what do? These goblet cells are epithelial cells that produce mucus. This mucus serves as a protective barrier in the mucosal linings, okay, to prevent the mucosal lining from being tampered with. But do you know, in asthma, these goblet cells in the airway begin to experience what we call hyperplasia. They increase what? In number. Okay, they begin to increase in number. And then due to that, they begin to go into what? Hypersecretory. So they produce the mucus in excess. Are you getting the point? So in asthma, after the inflammation sets in, the inflammatory mediators, okay, or the chemicals that are being released, act first on the smooth muscles to cause bronchoconstriction. Then after that, the goblet cells also begin to experience what? Hyperplasia and hypersecretory. Then they begin to do what? They begin to produce the mucus in excess, because naturally, everybody have the epithelial cells, the goblet cells, to produce the mucus to protect the airway. But in asthma, we say like the airways has been tampered with, the cells has been tampered with. So they become very hypersecretory, leading to excess production of the mucus and further blocking the airway. Okay, so we have the chronic airway inflammation due to the trigger, which we call the inflammation. Then the mucus production due to excessive production of mucus by what? The goblet cells, airway obstruction by the mucus production, and also the smooth muscle being what? Constricted. Then we are having what? A hyper responsive airways. So at a point in time, the airway becomes very, very sensitive to any contraction signal. So a little trigger, they begin to experience an asthmatic attack. This is what we are seeing in the patient with what? Asthma. Okay, this is what we are seeing in the patient with asthma. You are exposed to, let's say, a high-scented perfume, for example. The perfume begin to cause what? Inflammations in the airway. The inflammation release what? Inflammatory mediators or chemicals. These chemicals will act on the smooth muscles, causing bronchoconstriction, and it will further cause the goblet cells to produce more mucus to block the airway. And at a point in time, the airway becomes very, very hyper responsive. Okay, they are very, very sensitive due to excessive or various stimuli. That a little trigger will cause contractions in the airway. This is what we are seeing in asthma. Okay, all right. Now we have types of asthma. We have one, allergic, the non-allergic, two, and three, the occupational asthma. Okay, so one, the allergic asthma, it is triggered by allergens like pollen or pet dander. Okay, like pollen or anything cause what? The asthma. There are other examples as well. Okay, these are called the allergic asthma. Then we have the non-allergic asthma. Okay, triggered by like stress, exercise, or other respiratory infections. Okay, I will explain more when it gets to the risk factors about the stress and exercise, how they cause the asthma. Okay, then three, we have occupational asthma. Okay, occupational asthma is triggered by workplace exposures. Okay, workplace exposure. For example, yesterday we learned COPD. Okay, and we are able to establish that those who work in the mining industries, the construction site, because they are exposed to dust. Someone who works as a contractor, always on the road. Imagine you are always exposed to what? To dust. It can trigger what? Asthma. So these are some types of what? Or let me say the types of asthma: the allergic asthma, the pet dander, the non-allergic asthma, and the occupational asthma. Okay, the three of them. All right. So now let's talk about some of the risk factors, okay, of asthma, causes or some risk factors of asthma. Okay, so we have one, genetics. Okay, so family history can play a role. Okay, I think there's a question. Yes,
Yeah.
Madam. Yes, Madam Doris.
Sorry. Yeah, thank you very much. So I wanted to ask, I was just wondering, with the occupational asthma, can't it also be classified, or to an extent be classified as An
Allergic.
allergic asthma, yeah, because it's like a trigger, right? At the end of the day, if the person is not allergic to the dust, or is this just the consistency? That is consistency of their job. So because of that, they are introduced to it every day, and at the end of the day, they become at the end of the day allergic to it, or maybe it causes that. Please, I want an explanation on that. Thank you very much.
Okay, so as you said, it's kind of have a relation with the allergic asthma, okay? Because when you are working in those sites, that is when you are exposed to the allergies. Okay, and then let me even say this. The reason why usually it's occupational is because those triggers will not come unless you are, working. When you say occupation, it's occupation because it's working. Please. It's occupational because it occurs at the workplace. For example, we have occupational hazard. Why do we term it as occupational hazard? Because it's occurred at the workplace. Okay. It's occurred at the workplace. Yeah, are you getting the point?
Yeah,
So
thank you.
when you are working and then in those work environments, you are exposed to those allergens. That is why we usually classify them as occupational asthma. Okay. All right.
Yeah.
So we have one. You're welcome. So we have one, genetics. Okay. So family history can play a role in developing asthma. Okay. Most conditions we say that genetics play a role, right? Your mother had it, your father had it, and your close siblings. I always say this. Some of these things they ask on the NCLEX. If they ask you the first line family history or the first line relative to cause or you kind of related to lead to a condition, it is your mother, your father, and your siblings. Your uncle, your aunties are not part. Okay. So they are the first line relative to cause a disease. Are you getting the point? So asthma can be something the family, your mother will have it, your father had it, and then to be transferred on and on and on. Okay. So we have one, genetics. Then two, we have allergens, which we just spoke about. So exposure to allergens like dust mite, pollen, pet dander, can trigger what? Asthma, okay? Exposure to allergens like dust mite, pollen, pet dander can trigger asthma symptoms, okay? Three, respiratory infections. We have the viral respiratory infections can also trigger asthma, like cold flu. When you have cold, what occurs? You are exposed to the virus, okay? The virus begins to cause inflammations in the airway. Eventually, it can begin to cause smooth muscle constrictions, and further cause the goblet cells to further produce more mucus, okay? So when you are getting conditions like cold flu or other respiratory infections, that can also predispose you into getting what? Asthma, okay? Then four, environmental factors, exposure to tobacco smoke, air pollution, strong odors, okay, can contribute to what? Asthma development. So, for example, you are always around an environment whereby people are smoking, there's air pollution, strong odors like perfumes. All these are some of the environmental factors that can trigger asthma. Okay. All right. Then we have five, exercise. So physical activity can trigger asthma symptoms. So let me explain. Now, when you are exercising, because exercise is good for the body, so why will exercise trigger asthma? Okay. And then mind you, as you'll be talking about very soon, the fact that exercise can trigger asthma does not mean they don't exercise, like what we learned yesterday. Okay. Because exercise is good for the whole body. It increases peristalsis, it prevents DVT. Okay. So usually if a patient has asthma, and then vigorous exercise can trigger the asthma, we let them take the bronchodilator before the exercise, okay? We are going to get them. This is just by the way. So how does exercise trigger asthma? Now, let's pay attention. When you are exercising, what occurs? There's increase in metabolism. It was established yesterday, okay? The moment you exercise for a longer period of time, for example, running, or let's say jogging or something like that, there's going to be increase in metabolic rate. Metabolism will increase. Now, the moment metabolism increase, there's going to be increase in oxygen demand. Okay, there's going to be increase in what? Oxygen demand. Okay, now when oxygen demand increases, then at a point in time, you don't breathe with your nose alone. Okay, you see those, or if you watch, please can you mute up? Someone microphone is on. Oh, please. All right. So when you exercise, at a point in time, you begin to breathe through your mouth as well, not only your nose. Okay. For example, you're watching those who are athletes. I mean, they'll go through the 4 by whatever, okay, athletics. At the point in time, you realize that they are breathing with their mouth open because there's an increase in oxygen demand. So any way that air can enter the lungs, we have to get it enter the lungs, okay? So at a point in time, when you exercise for long, the body does not breathe through the nose alone. The mouth will begin to open to take in air. Now, here is the case. When you breathe through your nose, you know what occurs? There are structures in your nose made up of excessive blood vessels, or let me say, it's not even excessive, but it's made up of excess blood vessels, okay? And other structures in the nose warm the air before it gets to the lungs. Let's take note. Anytime you breathe in through your nose, there are structures in your nose that warm the air before it gets to your lungs. But when you breathe through your mouth, those structures are not there to warm the air. So the air will enter cold as it came. And anytime you are exposed to a cold environment, what occurs? Constriction begins to occur. Okay. So when you exercise for long, and then now air begins to enter through your mouth, there are no structures to warm the air. So the air enters cold as it came, and then this begins to cause constrictions in the airways, leading to what? A trigger of asthma. Are we there? So that is how exercise can trigger asthma. Okay. Then 6, we have stress. When you are stressed, what occurs? There's release of stress hormones, the cortisols, the catecholamines, and the rest. They are going to be released when you are stressed. Now, these vessels, or let me say, these stress hormones, what do? They begin to constrict blood vessels and airways as well, eventually leading to asthma. Okay. Then 7, medications like beta blockers. I think yesterday we learned how beta blocker, especially the non-selective one, can cause what? Asthma. They block beta 2, and eventually they begin to constrict the airway. So medications like beta blockers can further what? Can further constrict the airway, triggering what? Asthma. Okay. So these are some of the risk factors of what? Of asthma. Okay. All right. Any question, please? All right. There's no question, so we can move ahead. Okay. So now the clinical features of asthma. Okay. The clinical features. Is someone speaking? All right. The clinical features of asthma. We have one, wheezing. In fact, wheezing is a clinical sign of asthma. So a whistling or a squeaky sound that you hear when you are breathing out. Okay. So in asthma, what occurs? There's bronchoconstriction. The smooth muscles in the airway are being blocked. Okay. The smooth muscles in the airway are being blocked out in what? Bronchoconstriction. Are you getting it? And then also there's mucus production excessively. Okay. There's mucus production excessively. So air entering and air coming out in some way is a problem. Okay. So the body will try to compensate to pull the air out. In that manner, you begin to hear that wheezing sound. Yesterday I did it, okay? That sound is a compensatory mechanism, okay? It's an effect of the compensatory mechanism. The body is trying to pull the air or push the air, but it is meeting a hindrance. So that forceful nature gives that wheezing sound, okay? That forceful nature begins to what? It's forcing the air through the airway. Then we are going to get that wheezing sound, okay? Then 2, there's coughing, a persistent cough, especially at night or during exercise. When you are exercising, or let me say, when you're having asthma, there's mucus production. So the body will try to compensate to bring the mucus out, hence coughing, okay? The way the body will try to compensate is to cough. When I cough, I'll bring the mucus out, okay? Then 3, we have shortness of breath, okay? We have shortness of breath. Okay. You have shortness of breath. Also, when you exercise, because air is not willing to go through, you begin to what? Short breath. Okay. There's increase in oxygen demand, especially when you're exercising or you're doing a physical activity. And one thing you should know is that once you are doing those things, there's going to be an increase in oxygen demand. Here lies the case: the airway is being blocked due to mucus production and there's smooth muscle constrictions. Okay. So the air will not go there as needed, and this begins to lead towards shortness of breath. Then 4, we have chest tightness. Okay, chest tightness. This is due to the muscle constriction. Okay, the lungs. Yesterday, we all know, as you all know, the lungs is located beneath the chest cavity. Okay, we have our chest, and beneath our chest is the lungs. So anytime there's something wrong with the lungs, usually you can feel the pains on your chest because it's just under it. Okay, so in asthma, there's mucus production. There is what? Smooth muscles, tightness, constrictions. So this begins to cause an effect on the chest. So the patient begins to feel a heavy or a tight chest due to the smooth muscle constrictions. Okay. All right. Then we have 5, tachypnea. Tachypnea is what? An increase in respiratory rate. Okay. Tachypnea is an increase in what? In respiratory rate. Tachypnea will occur as a result of the same idea, compensatory mechanism. Air is not entering. Okay, so the body will begin to compensate to try and increase the rate to get the air in. Are you getting the point? The body will try to compensate, okay, to increase the rate just to get the air in, and then you're going to get the tachypnea. Okay, you're going to get the tachypnea. Then 6, we have retraction. But this one is usually seen in children, okay? And the retraction is common in children, though sometimes adults too can have it. Now, retraction is simply when the muscles around the lungs, the respiratory system begin to what? Squeeze itself to pull air into the lungs, okay? So you realize that the diaphragm is creating a vacuum, okay? The diaphragm begins to create a vacuum just to pull itself in to push air into the lungs. So they're going to get those retractions, okay? Then 7, diminished or absent lung sounds, especially in exacerbations, okay? So diminished or absent lung sounds, especially in exacerbations. So there's mucus production, and there is airway constrictions. So when you listen or you auscultate their lungs, they are going to have a diminished lung sounds, okay? And at a point in time, it's going to be absent, okay? You know, when a patient has asthma, especially in asthma exaggeration or exacerbations, and you don't respond to the issue as fast as possible, you know what is going to occur? There's going to be total closeness of the airway. The mucus will eventually block, or the constriction of the sweet muscles will become severe. Automatically, it will begin to block the entire airway. Okay, and then the lung sound is going to be absent because we are not getting anything in and out. Okay, so you're going to be diminished or absent lung sound, especially in exacerbations. Okay, then lastly, there's going to be what? Cyanosis or cyanosis. Okay, you all know what cyanosis is, when there is limited what? Amount of oxygen, okay, causing the bluish discoloration, which begins, usually you see it on our lips, okay, but sometimes it can extend to the body, okay. You begin to see bluish discoloration on the lips and then on the skin as well, okay. Then we see the patient is having what? Cyanosis. So these are some clinical features. Never forget wheezing, okay. Wheezing is common. Chest tightness, okay. The patient come to your ward, maybe you need an NCLEX question, a 55-year-old patient admitted to your ward, blah, 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 and you see some wheezing, you begin to think asthma, okay. Usually, they will associate wheezing with asthma, okay. And so wheezing is very, very common, coughing and the rest, okay. These are some key clinical features for asthma. All right. Any question? Any question? My co-host, you are not doing the work. I am still the one muting them. Please try and help me, okay? All right. Good. So now let's talk about how to diagnose a patient with asthma.
Yeah, Jeff.
Okay. So we have one, spirometry. Okay. So in asthma, it's part of the slides. We will talk well, or we are going to, learn a little bit about the spirometer. Okay. How we use the spirometer. Okay. We're going to learn more about how we use the spirometer. But just know that it is used to measure the level of obstructions in the lungs. Okay. You know, when you use a spirometer, it helps us to get the amount of air you are being able to do what? to inhale in. Okay, so in asthma, there is bronchoconstrictions, there's mucus production due to the excessive mucus production by the goblet cells. Okay, this will affect the airway. So we want to measure the volume of air that being inhaled in. Okay, so the spirometer can help us get that volume to help us diagnose what asthma. Then two, we have chest X-ray. So chest X-ray, we are going to see once again a hyperinflation and a flattened diaphragm. But please take note. Usually, on your NCLEX, for exam sake, usually you associate hyperinflation, flattened diaphragm with COPD more. Okay. Okay. On your NCLEX, usually they will associate hyperinflation and flattened diaphragm with COPD more. So please let's take note. Okay. So hyperinflation and flattened diaphragm, because there is airway constriction. Are you getting a point? It's the same idea. There's airway constriction. So even if the air is able to go out, but one thing is that here it is not like COPD that the air sac has lost elasticity. No. Okay. At some point, the air sacs are working. They have the elastic intact and they are working. But one thing is that there is airway constriction. So even if the alveoli works to bring the air out, because the constriction is there, not all of them will come. This will eventually cause some hyperinflation of the lungs. Okay, and if you don't treat the condition, it can begin to cause or it begins to become more accumulate, and it can cause a flattened diaphragm. Okay, because the air is not really coming as it should come. Okay, through the airway, it can cause hyperinflation and can lead further lead to the flattened diaphragm. Are we there? Good. Then three, we have a reduced peak expiratory flow rate. Now, let me just use this as an example. Okay, breathing in seconds. Okay, breathing in seconds. Okay, breathing in and breathing out in seconds. Okay, so you just breathe in air, you breathe out. Normal, you did normal without even knowing that you are doing breathing. Okay, but the moment you get asthma, there is bronchoconstriction, mucus production, blocking the airway. So all right, Madam Jamila, I'll go back. Okay, when I'm done with this, I'll go back to the signing symptoms. Okay, all right. So there is increase in what? Mucus production. There's airway preventing enough air from going out and coming in. This will increase the time to take. Please, now, if I see your microphone on, I will kindly take you out of the class. Please. All right. So we have spirometer or spirometry, then chest X-ray, then reduce peak expiratory flow. It distracts the class. Please, let's kindly have a coordinated class, okay? To reduce peak expiratory flow rates, okay? Reduce peak expiratory flow rate. When the airways are being blocked, the time it will take for the air to leave the lungs will now be prolonged, because it is taking time for the airway to come out. Okay, it is taking time for the air to come out. Are you getting the point? It is taking time for the air to come out because the airways are being blocked. So if you use, let's say, 3 seconds to breathe in and out, now the time will increase. Are you getting the point? The time is going to increase because there's airway constriction. Just imagine that maybe you use 1 second to enter a place. Here lies the case. Someone is standing at the door to prevent you from entering. Don't you think it will take time for you to enter? Okay. So when people are there to block you, you're not going to go. It's the same way. When the airways are being blocked, the time to take for the air to pass through will now be increased. That is why I'm going to get a peak flow rate be reduced. Okay. So if you are going to use a flow rate of, let's say, what do you call it? Let's say 2. Okay, now is going to be long, very, very, very long. Okay. So the rate at which you are going to what, expire the air through the airway is going to be very, very long. Are you getting the point? That is why I'm saying there's a reduced peak expiratory flow rate. Are you getting the point? Good. And then I'm going to get ABG. Please, who is muting? Someone muted me, please. Why that? All right. Please, can you hear me? If you can hear me, just send a message or raise your hand and let me know if you can hear me.
Oh.
Okay. I think you can hear me, right? You can hear me. Okay. All right.
Yes.
Right. Very good. So as I was saying, in asthma, there's a reduced peak expiratory flow rate, okay? Because the airways in the lungs becomes narrow, making it difficult to exhale, okay? So the rate is being reduced. The rate, if you are going to breathe out faster, now that rate has been reduced. Are you getting the point? That is what we mean by a reduced peak expiratory flow rate. So if you are breathing in early, like you are using 2 seconds, now it's going to take long because it is taking too much time. Okay. So that faster rate is now reduced. Okay. That faster rate is now reduced to bring the air out. That is why I'm going to get a reduced peak expiratory flow rate in what? In asthma. Okay. Then lastly, we have ABG analysis. Okay. We have ABG analysis. Okay. We have ABG analysis. So they're going to be high partial pressure of CO2. Okay. In the same way as we learned in COPD, there's airway constriction. So air is not really going out as expected. Okay. Air is not really going out as expected. And this is eventually going to do what? Going to cause excitation or CO2 being retained. There's going to be high partial pressure of CO2. When we get high partial pressure of CO2, we are leaving the patient in what? In respiratory acidosis. Okay. We are leaving the patient in respiratory acidosis. Okay. All right. So these are some of the investigations that we can do to diagnose a patient with what? With asthma, including the physical examinations, like, okay, including physical examinations, like the wheezing, to be specific, okay, the wheezing, okay. All right. That's fine.
Please, I have a question.
Okay, so let me, you can answer the question. Yeah.
Okay, please. So the hyperventilation is respiratory acidosis.
When you hyperventilate, okay, it means that we are breathing fast. Are you getting a point? For example, a patient with I nearly say asthma, anxiety. When you are anxious, you breathe fast. So you take more carbon dioxide out. Okay. You take more carbon dioxide out. So you are going to bring all the acid out. So this one will lead to respiratory alkalosis. You are bringing the carbon dioxide out due to the faster rate at which you are breathing. Okay. Due to the faster so you are going to bring all the carbon dioxide out, leaving the base. Okay. Are you getting the point?
Yes, please. Thank you.
Welcome. Yes, Mr. Yusuf. You can talk, please.
Okay. I think that was yesterday. I had a question let's achieve, and then they were like severe asthma. Is it respiratory acidosis or respiratory alkalosis? So I went for respiratory alkalosis, and then it was wrong.
Yes.
And then okay.
I'm listening. Please continue.
So the rationale was that if it is asthma, when I get acute asthma or asthma, that means that the patient is going to have respiratory alkalosis. But whenever they say severe asthma, because they say severe, that means that the respiratory muscles will be weakened. So therefore, there wouldn't be hyper ventilation, and then CO2 will be remain, which is acidic. That is leading to respiratory acidosis. So we have respiratory acidosis in severe asthma, but we have respiratory alkalosis in asthma or acute asthma.
Okay, I get your point. Okay, yes, I get your point. Because when especially when you are having the asthmatic attack, at that point, usually you want to. That is why I think I explained, right? They have tachypnea. Are you getting a point? If you asthma patient will have a tachypnea. They begin to increase their respiratory rate to compensate for the limited amount of oxygen entering the airways or the lungs. And then anytime you are hyperventilating, you are bringing carbon dioxide out. It is a fact because you are breathing faster. So oxygen is entering, carbon dioxide is going out. Okay, so you are going to bring carbon dioxide out. But then while you are hyperventilating, as Mr. Yusuf said, in what do you call it? In severe asthma, there's exacerbations whereby the airways are not being open. You are not getting the lung sounds and the rest. The air is going to harbor, okay, or the carbon is going to increase because there's limited rate of respiration, leading to hyperventilation. You're going to go into respiratory acidosis. Okay, so let's get that. Okay, let's get that very, very key. Okay, let's get that very, very key. All right, so these are some of the ways you can note to diagnose a patient with asthma. Okay, all right. Oh, all right. Can't go to next. So let's talk about the interventions. Okay, so we've dealt with the signs and symptoms, the diagnostic investigations. So let's talk about the next interventions. Okay, on our NCLEX, in as much as everything is important, the most important, if I'm to rate the priorities, okay, the most important should be your next intervention. You should really know. I mean, the next intervention is very, very, very well because the exams is about USRN. Okay. Can I see the signs and symptoms? Sorry, okay, let me go back for you to see. Because have you seen it, madam? Is it Jamila or something? No. All right, so I'm sure you've seen it now. Right, good. All right, so you should focus more when it comes to nursing interventions because the exams is about NCLEX and the nursing duties, the nursing interventions mostly. Okay, all right. I'm not saying others are not important; they are equally important. Okay, so how do you manage or how do you intervene with asthma? So in the same position, one, place the client in high Fowler position, but tripod in what? Exacerbations. Okay, so when a patient asthma is well controlled, probably the patient has taken their bronchodilators, the long acting, the short acting, they are okay. The airways are being opened. Okay, the airways has been opened perfectly. Are you getting the point? The airway is now open and the asthma is under well control. They should always be in a high Fowler position. But the moment there's a severe closure of the airway, they must assume a tripod position. So when you meet this question on your NCLEX, as I said yesterday, a patient was admitted to your ward with asthma, and they added asthma exacerbation, or severe asthma. Which of the following position should the patient assume? Please, it's tripod position. Don't pick high Fowler. High Fowler is when they put only asthma, okay? But in asthma exacerbations, and remind you, always the NCLEX will bring it. If they want you to pick the answer for exaggeration, they will note it there. They will usually bring it there, okay? Like the question that Mr. Yusuf just spoke about. They stated the severe. Are you getting a point? They give the rationale for you to suit that in severe, you are doing what? You are doing respiratory acidosis, but in the acute, it is what? Alkalosis. Are you getting the point? So always the NCLEX will make you know that this is asthma exaggeration, and then you have to pick the tripod for that. Okay, but when the asthma is under control, please pick a high Fowler position. 2, administer supplemental oxygen. So here I'll ask some few questions. Okay, we give a patient with asthma oxygen to increase their saturation level, probably to around 97, 98, and the normal level. Okay, this patient, we can give them high level oxygen. It's not like COPD, no. Okay, so we can increase their SpO2 to around 97, 98, and it is fine for them. Okay, so please, let's administer oxygen to a patient with asthma to help them what? Prevent respiratory failure and to help them sustain them respiratory. Okay. All right, now when we are giving asthma, when I'm giving oxygen, when I'm giving oxygen to a patient with asthma, okay, there are oxygen precautions that usually we see on the NCLEX. I want us to just use some few minutes that we have to go over them. Okay, yes. So it's a question. Any idea you have on what do you call it? The general precautions when it comes to asthma. I'm saying one of them, and then I'll leave the rest for people to also come in. Okay. So when you are giving oxygen to a patient, you don't put a petroleum jelly, a petroleum or oil around the patient's body or the cylinder. Okay. So you meet a question on the NCLEX. A patient was admitted with asthma, and the patient was placed on what? On oxygen. Which of the following precautions should be what? Implemented to prevent or to enable free oxygen administration? So 1, do not put oil or petroleum jelly on the patient's body or the cylinder. It can combust fire. Okay, it can combust fire. Yes, any other? Yes, you can raise your hand, I'll call you. Okay, Madam Tina. Yes. Madam Tina.
Please, you shouldn't smoke around the cylinder.
Okay, so you shouldn't smoke around the cylinder. Okay, so in that, you also place what? A no smoking sign on the patient's door. Okay, you place a no smoking sign on the patient's door. Are you getting the point? So that all those coming in as well, not only the patient, all those coming in will also know that these patients, you shouldn't take anything smoke around them. Okay, or like let's say cigar around them. Okay, yes, any other? Madam Nanekia, I see your hand.
Yeah, it's almost the same. It should be free from a fire source.
Okay, all right. So we have those portable cylinders. Okay, those portables that can be used in the house. So when a patient is being admitted or is being discharged with those portable cylinders, they have been advised to what? Not take it closer to gas stoves as well. Okay, they shouldn't take it closer to gas stove as well. At least it should be some meters. Some meters should be between them to prevent it from catching fire. Okay, are you getting the point? Yes. What again? What again? Yes, on the neck here.
So you also have to taper it gradually. You don't have to stop it abruptly in case you are weaning the patient off from the oxygen. And you don't have to also overgive. Yeah.
Okay. All right. Madam Naomi, any addition? Madam Naomi.
I think it should also be kept in an enclosed area where there is too much heat.
Okay. All right. So one last question. If a patient, okay, let me allow Madam. Maybe it's good to say that answer. Madam Rahman.
And you also have to use a humidifier to prevent crackles in the nose.
Okay, that is good. So that the air will be a bit warm, right? Okay, good. One last question. Nobody has said it. So I'll ask the question. So when a patient is admitted and then it's being given oxygen, should you clothe the patient in a cotton blanket or a wool blanket?
A cotton blanket.
A cotton blanket, not a wool blanket. Right. Okay. So please let's take note. Okay. A cotton blanket. Okay. Okay. Yes, Madam Esther.
So today I saw another one. They said if the patient has oxygen in the house, they should call the power control system in case there's power outage.
Mommy, who the one who you are there? You need to know why. Now you are there. One obi obey my phone say baby other than sass. Who the jan? Who the jumana?
Good. All right. So that is it. Okay. And then I see something here also. It says you install what smoke detectors or smoke sensors in the house. Okay. So all these contribute to what? To the oxygen precautions. Okay. Yes, Madam Nekia.
Zaki, I also came across having a fire extinguisher around in case there is.
You quench the fire. Perfect. So these are the precautions you should know when it comes to what? When it comes to oxygen administration. Very key on your NCLEX, okay? Please, you've been saying them all. So when you meet them, let's try and get them right. Then 3, you auscultate the lungs before and after treatment. For example, a patient was admitted, you auscultate the lungs and you are hearing wheezing, okay? Or let me say diminished lung sounds. Now, after treatment, you give bronchodilators, you give corticosteroids. Please note, after the treatment, you should auscultate and see if there is what? You have achieved your goal by opening the airways, okay? So you must auscultate the lungs before and after treatment as well, okay? Then 4, you monitor for vital signs like the pulse oximetry and the peak flow meter. Peak flow meter, we'll talk about it very, very soon, okay? So you monitor the vital signs and then you monitor what? Please, Emmanuel, you are right on my screen. Mister, please. Okay. So you monitor the patient vital signs, the pulse oximetry, and then the peak flow meter. Very, very, very key. Okay. Then 5, you avoid triggers. You know yourself. If you have asthma, you know yourself. Or if you are an RN, you should know your patient. From where? From history taking. Okay. The patient was admitted, you took history. So you know some of the things that would trigger what? The asthma. So you know them and then you list them down. Then you educate the patient to avoid them. And then you also advocate on the patient behalf to remove any triggers from the patient environment as well. Okay. If whether it is dust, it is high scented perfumes or whatever that will trigger the asthma. Do as well to avoid those triggers. Okay. To bring the asthma under control. Then 6, if wheezing stops immediately without if wheezing stops immediately without treatment, it indicates severe airway blockage or obstruction. Please, let's take note. Because, a patient with asthma will present with wheezing. Why? Because air is trying to force its way through the airway. Are you getting the point? That's why we're going to get wheezing. Okay. So after treatment, we should get the wheezing to stop. Are you getting the point? After the treatment, we should get the wheezing to stop. You shouldn't have any wheezing again after the treatment, okay? But if the patient comes to the ward or probably the ER, so your patient was rushed to your ER unit, you were the RN on duty. The patient came with wheezing to the point that even if you don't auscultate, you can hear. Then all of a sudden, without giving any bronchodilator whatsoever, the patient wheezing has stopped. Please, it indicates severe airway blockage. So when you meet this question in the NCLEX, please pay attention. Don't let them trick you. Okay, a 55-year-old male patient was admitted to your ward complaining of excessive wheezing or on auscultating. The RN could pick wheezing. After 5 minutes without any treatment, the patient wheezing has stopped. What does this indicate, or what do you expect, or what do you observe? You must know that the airway has been blocked. It's an emergency now. At this point, you need intubations. Okay, you need intubations, mechanical ventilator to prevent what? Respiratory failure at this point. Okay. So please take note. If wheezing stops immediately without treatment, it indicates severe airway blockage. Okay. Right. Then 7, monitor for retractions and cyanosis. Okay. Especially the retractions, you have to monitor how is the muscles moving, how is the diaphragm moving. Is the diaphragm creating any vacuum? Okay. Is there any vacuum below the diaphragm? The patient's breathing. Monitor for all these retractions and the cyanosis as well. Okay. Let's take note. So you went for cyanosis. Is there any bluish discoloration, okay, around the patient's mouth or the lips? All this indicates what? A diminished oxygen or entry into the lungs. Are you getting the point? So all this, you should monitor them for a patient with asthma. And then 8, take short-acting beta agonists. Example is the albuterol before you exercise. Okay, take a short-acting beta agonist before you exercise. As I explained, exercise will increase what? Oxygen demand. You begin to breathe through your mouth as well. At that point, the air will enter your mouth and then it is cold. There's nothing in your mouth to make it warm. It will constrict the airway further. But you don't have to stop exercising because you need it for the general well-being of the body. So to prevent that oxygen demand whilst you're exercising, to prevent shortness of breath, take a short-acting beta agonist before you exercise. Okay, example is the albuterol. So if a patient or you know someone with asthma, they must always take the albuterol or their inhalers before what they can exercise to prevent any shortness of breath and then further airway constriction due to the entry of air into the mouth into the lungs through the mouth. Are you getting the point? So these are some of the interventions that you should take note of when it comes to what? Asthma. Okay. All right. Please, any question? You can raise your hand if you have any question. Any question? All right. I think you are cool. All right. Good. Now, pharmacology. Let's talk about the pharmacology. Another key area for our NCLEX. Okay. Another key area for our NCLEX. Please, let's take note. So, 1, inhalers such as bronchodilators can be given to a patient with asthma. Now, we have 2 types of the bronchodilators. Okay, we have 2 types of the bronchodilators. So 1, we have the SABA, the short-acting beta agonist, and then 2, the LABA, the long-acting beta agonist. Okay, so it's SABA for OMO. Okay, so just remember that. The short-acting beta agonist, and then LABA, the long-acting beta agonist. Example of the short is what? The albuterol, and then the long is salmeterol. Please take note. Don't say they are all bronchodilators. Don't give long-acting beta agonists. Example, salmeterol in acute, or let me say in asthma exacerbations. No. It's a long-acting bronchodilator. It will take long before it can dilate the airways. So don't say they are all bronchodilators. In an acute, or let me say in a severe form of asthma or asthma exaggerations, please give the short-acting. It will take a short time to dilate the airway, then air can now enter. Now, this is what you should know. Don't get strict on the NCLEX. It shouldn't be used every day. The albuterol inhalers, okay? It shouldn't be used every day. It should be used at least twice a week. Now, why? If a patient reports to you that I used my albuterol inhaler all the time, it means that the asthma is not under control or the asthma is not well controlled. Why should you be using short-acting beta agonists every day? It means that every day you go into exacerbations because that is when you need the short-acting. Are you getting the point? If you are taking albuterol or the short-acting beta agonists all the time, every day, it simply means that consistently the patient is having what? A bronchoconstriction every day. The airways are being blocked. That is why you keep on using the short-acting. So it shouldn't be used every day, but at least twice a week. Okay, at least twice a week. But the long-acting, okay, probably you can use it for several times because it's a long-acting. Okay, it's a long-acting. So if the patient tells you, I keep on using my long-acting, that one is fine. Okay, but for the short, it shouldn't be used every day. It signals you the iron that this patient asthma is not under control. That is why every day he's using something short to open it or dilate the airways. Are we getting the point? Very good. So we give them the bronchodilators to dilate the airways. Then after that, we give the corticosteroids for what? To treat the infection and inflammations. Okay. So we give corticosteroids to treat the inflammations in the airways. All right. Good. So we give an example of the methylprednisolone. Okay. Then yesterday we learned this, the 8S. Anytime you are giving steroids, remember the 8S. Okay. So sepsis, sugar, sex, weight gain, all those things are there. Remember them. Don't forget. You can get a case study question, and your first question, you diagnose the patient asthma, you had it right. Second question will be let's assign the symptoms. Then third question, the patient has been put on steroid. Now patient is having high sugar level. Then they begin to ask questions on those areas. Okay. Third question, the patient is being put on steroids. Then the patient is starting getting infected. It means that the steroids is decreasing the immune system. The patient is getting infection. Then you can ask questions on those things as well. Okay. So please know the 8S when it comes to steroids. Okay. And it is given primarily to treat the inflammations. All right. Another class of drugs we can give is the anticholinergics. Example is the ipratropium and the tiotropium. Okay. So here to just get the difference. Okay. Ipratropium and tiotropiums, all of them are anticholinergics. Okay. But the ipratropium you will say is a short-acting anticholinergic, and the tiotropium is a long-acting anticholinergic. The time it will take for the ipratropium to have its effect on the airway is very, very high. Okay, it's very, very high as compared to the tiotropium. So let's take note. And yesterday we were able to learn that anticholinergics dry out secretions. So yesterday I mentioned a particular neurotransmitter that this drug will block, causing the drying up of secretions. Who can remember the name of that neurotransmitter? Yes. Raise your hand, let me call you. Yes. Hey, yesterday we were here. Acetylcholine. Okay, so someone has sent in the chat box. Acetylcholine. Okay, so they block acetylcholine, right? Acetylcholine naturally helps to provide or produce mucus. Okay, naturally it helps to produce mucus. But when you take these anticholinergics, they begin to block this acetylcholine that produce mucus, hence drying up what secretion. So there's going to be low sweat production, low tears, low sweat production, low tears, low urine output. They are blocking what mucus and the drying. So what the moment you see ipratropium, tiotropium, anticholinergics, know that there's limitation of fluid, no fluid or reduced fluid production. Okay, just know that low fluid. So having said that, there's a condition common as well on our ankles. When you have this condition, you don't produce fluid at all. Okay, you are going dry, vaginal fluid dry. Even when you want to have sex, in fact, there's no fluid for lubricant, nothing. You don't have tears, you don't have sweat. What's the name of that condition?
Surgery disease.
Surgeon's syndrome.
What?
Surgery.
Surgery. So the S is silent. Okay, let me type it in the chat box. Okay, the S is silent. Okay, so it is Sjogren's syndrome. Okay, Sjogren's syndrome. You can pronounce it like that. Okay, Sjogren's syndrome. Okay, so this condition, when you have this condition, the patient does not have the patient does not have secretions at all. Okay, the patient goes dry. Just know that the patient goes dry. In fact, total dryness. Okay, total dryness. They go dry. Okay, total dryness. That is something you should take note of when the patient have this Sjogren's syndrome. Okay, Sjogren's syndrome. So that is it. Right. Good. And then they dry up secretions. Anticholinergics dry up what secretions. Okay. Then theophylline. Yesterday we learned something about theophylline, right? We said that what it does what does theophylline does to digoxin? Yes. What does theophylline do to digoxin?
It increases digoxin toxicity.
Okay. Yes, Madam Tina. And what again? We learned two things yesterday. Digoxin toxicity and what? Madam Tina, your hand is up. Madam Abigail, yes.
It makes lithium it reduces the effect of lithium.
Okay. All right. So we learned this yesterday. Theophylline also can be given to kind of open the airway. Okay. It can also give in to open up the airway. So we learned yesterday that it decreases, okay? It decreases, it increases the gauge toxicity, okay? It increases the gauge by doing what? By reducing potassium. Okay, so when you take theophylline with digoxin, it will decrease the potassium level, and then it increase what? Digoxin toxicity. And then also, it contributes to the excessive excretion of lithium, thereby affecting the effectiveness of lithium. Now, today, we are learning two things in addition to what we learned yesterday. Don't forget, okay? We are learning two things. Okay, we are learning two things in addition to what we learned yesterday. One, so we give theophylline orally. Okay, so usually theophylline should be given orally. So per oral, PO. And then you have to avoid cimetidine and ciprofloxacin when you are taking theophylline. They also increases theophylline toxicity. Okay, so don't take Cipro. So you have this question on the envelope. A patient was admitted to your ward with asthma. The physician prescribed theophylline. Which of the following medications should you clarify? If the patient is already taking them, you should clarify what ciprofloxacin, cimetidine. They will further increase theophylline toxicity. So don't give cimetidine and then cipro with theophylline. No, it will increase the toxicity of what? Of theophylline. Okay, are we right? Are we there? All right, and then we know that therapeutic range is 10 to 20 microgram per ml. Have you seen it? Microgram, very, very small. A few therapeutic index. So when you're mistaken, it's going to go into what? Toxicity. Okay. All right. So that is that for theophylline. Yes, Madam Nenekia, I see your hand up.
Yes, but Saki, please, I didn't really get this one well. The theophylline, you said it increases the digoxin toxicity.
By decreasing potassium.
Yeah, and that of the lithium too, or the lithium is not part.
The lithium, no, that one is different. For the lithium, it increases. When you take lithium with theophylline, theophylline will increase the excretion of lithium through the kidneys. So if it will take, for example, if it will take lithium 10 minutes to work on the body, now because there is theophylline will increase the excretion. So it will be excreted within 5 minutes. So that effectiveness we need will not be achieved. Are you getting the point?
Yeah.
So that is what theophylline does to lithium. It decreases the effectiveness of lithium in the body by increasing excretion of the lithium. Okay.
Okay. Thank you.
All right. So that is it. Please, are we there? Are we there? All right. I see a question in the chat box. It said, when you start having a side effect of, what do you call it? Anticholinergics, the dryness, do you stop the medications? Do you stop taking the medication? Okay. All right. So when it comes to drugs, generally in drugs, the best way to stop taking the drug is to taper it down. Okay. Let's taper it down. Usually, when you stop taking drugs abruptly, they are not good. Okay. And in fact, to be precise, you don't have to stop taking anticholinergics abruptly. No, you taper it down, then eventually you stop. So you reduce the dose consistently or gradually. Let me put it that way. You reduce the dose gradually, and then you now stop it. But when you stop it abruptly, it's no good. Okay. You don't stop it abruptly. Okay. All right. So that is something you should take note of. So you taper it down gradually before you stop the medication. All right. That is fine. Yes. I can see a hand up, but your name is not there. I see 1 4 something. Please kindly talk.
So does it mean you can't give IV theophylline at all? I know we have aminophylline and things which are also in the IV form. Does it mean theophylline? I'm not too sure. Theophylline is the tablet form or what? Or is the IV prohibited, or I don't know. A little explanation.
Okay. But first of all, I want to find out who is theophylline the same as aminophylline? Okay, so all right, that is fine. So you can give
Yeah, I know
theophylline.
aminophylline is also a bronchodilator. They give it,
They
they
kind
add
of
it
fall
to
in
infusions and then.
yes, they kind of fall in the same class. Okay, uh-huh. Yes, you can give theophylline IV. Okay, you can give theophylline IV, but most at times we give it orally. Okay, because why would we even try to give the theophylline orally? Simply because sometimes they determine that when you are getting the bronchoconstriction, ideally they would have tried to even give it IV, okay, but sometimes they will tend to give the theophylline orally most at times, okay, to help open up the airway, because usually when you give the theophylline IV, it takes a few time to be metabolized, because now it is through circulation. Are you getting the point? So the time it will take to uh, enter into the therapeutic index is very, very fast. If you don't take care, you are at higher risk of getting what toxicities. Are you getting the point? So usually they will try to give it through the oral route when it comes to theophylline. Okay, administrations for what? Bronchospasms. Okay, all right. But you can give it IV. You can give theophylline IV. Okay, you can give it IV. Okay, all right. So that is the point. So that is that for theophylline. So we've learned 4 things when it comes to theophylline for your NCLEX, right? One, it increases decreasing toxicity by doing what? By reducing potassium. And then 2, it increases what? It increases excretion of lithium. Okay. Then okay, we learn the therapeutic index with is 10 to 20 microgram per mil. Then cemetery and ciprofloxacin to be avoided when taking theophylline. They also increases what? Theophylline toxicity. Very good. Then we have this drug. Is a multi-class. Okay. This drug is also being given in asthma, but then it's not given in acute attack. For example, if a patient comes to your ward, and then the patient is having asthma exacerbations, don't give this the multi-class. Okay, don't give it, because when you give it, it's not going to have any impact immediately. Okay, so that is something we should take note of. Now, how does this drug work? It blocks the leukotriene. Leukotriene are chemicals. Okay, leukotriene are chemicals. Leukotriene are chemicals. That's what? That constrict the airways. But this drug actually block that leukotriene. So the class of this drug, we can call it leukotriene receptor blockers. Okay, leukotriene receptor blockers. That is what you can call this drug, the class, a leukotriene receptor blocker. Okay, so it blocks this leukotriene, which constrict the airways, so that the airway can now be open. But mind you, you don't give it in acute attacks. Okay, don't give it in an acute attack. Don't give leukotriene in an acute attack. Are you getting the point? Very good. Then we have the omalizumab. Okay, or let me say omalizumab. Okay, it decreases what allergic response. It kind of work like an antihistamine. You know, in asthma, you are exposed to allergens, and this is causing what? The mucus production, the bronchoconstrictions, and all those stuff. So we can give a drug like this, okay, to decrease the allergic response and then protect the airway, okay. So omalizumab, okay, you give it in a patient with asthma to decrease what? The allergic response. So all these drugs can be given, but in acute asthmatic attack, please, we give the bronchodilator. To be specific, the short acting, the albuterol. Okay, we give the albuterol. Please, let's take note. Okay, we give the albuterol to open and dilate the airways. Then we can now start giving the long acting, the corticosteroids, okay, the anticholinergics, and then the rest, okay, to help open up the airway. So these are some drugs you should know for your NCLEX. Okay, these are some drugs you should know for your NCLEX. Okay, these are some drugs you should know for your NCLEX. All right. Please, any question on this slide? All right. I don't think there's any question, right? Good. So we can move ahead. So now let's talk about the peak flow meter. Okay. The peak flow meter. Okay. The peak flow meter. So the peak flow meter helps to measure the amount of air that is pushed out of the lungs as you expire. Okay. Or you exhale. Right. So in asthma, what is occurring? There is bronchoconstriction due to the inflammation, and then there's release of inflammatory mediators acting on the smooth muscles. Okay, there's mucus production as well, so the airway is being blocked. So the volume of air that is entering and leaving the lungs is being diminished. Okay, so we can use this peak flow meter, right? We can use this peak flow meter to help the air to be pushed out of the lungs. Okay, so let's take note. We can use this peak flow meter to help or to measure the amount of air that is being pushed out the lung as you expire or you exhale. Are you getting a point? So when you use the peak flow meter, we have the recordings there, which we are talking about very soon. Okay. When you use, if you are agreeing, we record. If you are ready, record. Then we can know the amount of air that is being pushed out of the lungs as you exhale. Now, you record your personal best over a period of 2 to 3 weeks when the asthma is in good control. Okay. So when you are being discharged and then your asthma is under control, then you use this machine to help us get your personal best. Then you note them down. Okay. Then from time to time, any measurements will be recorded, or let me say, will be compared to your personal best recordings. Are you getting the point? So once you use this device, it helps you to get a particular recording or a measure of the amount of air that gets out of the lung as you exhale. Okay, then you record your personal best within a period of what? 2 to 3 weeks. Okay, when your asthma is under control. When your asthma is not under control, you are having exacerbations, you are not going to use the peak flow meter to get a right reading. You get it? It will not help us track your maintenance plan. Okay, it will not help us plan or track your treatment very well. Right. So we have some markings on the device. So as you can see on the image, or with the image on my screen, we have the red, the yellow, and the green. I get the point. So when you check or when you measure the volume of air, and then the marking gives you less than 50%, it means that there is a severe obstruction of the airway. Okay, when you check and you are less than 50%, it means that there's a severe airway obstruction. Okay, when you check and you are yellow, that is 50 to 79%, it means that there is mild symptoms. Okay, there is mild symptoms, and this is cautioning you that the asthma might be worsening. At this point, start using your inhalers. Actually, the peak flow meter will guide you when it comes to the maintenance plan. Are you getting the point? The peak flow meter guides you with the maintenance or to help you develop the action maintenance plan. Okay, the maintenance plan. So when you use the peak flow meter and you are at yellow, 50 to 79, please start using your inhalers to open up the airway, okay, to prevent the asthma from getting worse. Because if you don't use it, when you are yellow, eventually you are nearing red, and at red, you need hospitalization. Okay, you need straight hospitalizations to help open up the airway. Then green is 80 to 100%, and at that point, we say the patient is okay. You don't need anything. I mean, at that point, you are okay. You can just live your normal life as you always do. Okay, so please let's know the readings very well. I mean, this is what the entrance will ask you. They will just bring a question and they'll tell that the patient was below 50. What should you do? Are you getting the point? So it means severe obstruction exacerbation. That point, you need hospitalization. Okay, even possible intubation must come in. Okay, or use your short-acting bronchodilators to open the airway as fast as possible. You're getting the point. Then you have the yellow, then the green. You are fine. Okay, so you use the peak flow meter when you are probably discharged. Okay, or maybe your asthma is under control. Okay, together with the maintenance plan. So the maintenance plan, we have the corticosteroid inhalers, the long-acting beta agonist. Okay, and then you have a three. Always take the bronchodilator before the steroid inhaler, whether it is a drug or an inhaler. Please take note. Always the bronchodilator comes first. before the steroids. Okay, always take note. The bronchodilator comes first before the steroids. Always, the bronchodilator comes before the steroids will come in. Okay, so we have the steroids inhalers. The steroids inhalers is being given to treat infection. So whilst you are there to help us maintain your asthma under control, the maintenance plan, please consistently use your corticosteroid inhalers to do what? To help treat the inflammation. Okay. Then the long-acting beta agonists as well to open the airway. Then 3, since you are going to use the 2, the bronchodilator first before the steroids. Then 4, use an inhaler 30 minutes before you exercise. Before you exercise, always use the inhaler 30 minutes before to help open up the airway, okay, so that you don't short breath as you exercise. Then 5, use of short-acting beta agonists as needed. I said something, okay, in the previous slides that you don't use short-acting beta agonists all the time, right? I said that at least twice a week is enough. If you are using your short-acting beta agonist all the time, it simply means that your asthma is not under control. So for the long-acting, that is fine. But for the short-acting, if you find yourself using it all the time, your asthma is not under control, you need to report for further assessment and management. Okay. So if the patient is consistently using the short-acting beta agonist, it calls for what? For concern. So you use them as and when it's being needed. Probably the patient asthma is worsening. So we really need the short-acting to open the airway so that we don't go to red. Whereby there's a severe obstruction, then maybe intubation will come in. Are you getting the point? So when you use the peak flow meter and you're at yellow, that is where maybe you can start using a short-acting beta agonist to help open up the airway, okay, so that you don't go to red. Are you getting the point? So that is that for the peak flow meter. And then, knowing about the maintenance plan, they're using a bronchodilator before the steroids, having a long-acting beta agonist, knowing that the short-acting is used as and when needed, like a PRN, okay, like a PRN, okay. If the patient happens to use it all the time, it calls for a concern. So you should know this for the peak flow meter on your NCLEX, okay. All right, please, any question? Okay, Mr. Yusuf, I see your hand up. Yes, you can speak.
Yes, I want to share something with my classmates to explain the peak flow meter.
Okay, you can go
using,
ahead.
Using our this in the semester exams results back in school. Whenever like the master is in to share the papers, and then they mention your name, and then you get it, and you get below 50. That means that for that paper you are failing. And then if you get 50, and then you are not up to maybe 100, then that means that you are just between, though you pass. So that means that it is said that if you get less than 50, that means you pass, you fail in class, you are under red, which is severe obstruction. And then if you have made the pass mark, which is 50, you are in the middle. That means that you are in the yellow zone. That means that you are not the best in class, you are not A or B, but you did not also fail. And then the last one, the green, which is those who had the D's and A's. That's how I see it. Or use, yes, or you can also use this the traffic lights, red, yellow, and then green, so that this balance will not be confusing.
Okay, so red means stop, right? Yellow means get ready to worsen it, and green means you can go. Right. Okay. It's a good thing. Okay. It's a good thing. Okay. It's really good. All right. Thank you for that. Madam Jennifer, I think you want to ask a question.
Okay. Boss, I want to know how it's used. How is it used?
Which one?
The flow meter. Is it that you
peak
blow air into it, or how is it used?
Okay. I think it's on my slide. I don't know. You get there. But then the peak flow meter, how do you use it? You are exhaling through it. Okay. You are exhaling through it. So when you are being asked to use a peak flow meter, this is what you do. So you position yourself. You assume a good position, a sitting upright or standing. Then you take a deep breath. Okay, filling your lungs completely. Then you hold your breath. Okay, so you take in a deep breath to fill your lungs. When you breathe in air, you fill your lungs. You get it? So it should be deep so that you fill your lungs. Okay, then you place the mouthpiece of the device, okay, in your mouth, and then you seal your lips around it. Okay, you seal your lips around it, making sure that probably there's nothing blocking the airflow. You get it? Then you blow as hard and as fast as you can with a single breath by exhaling. You get it? Then you read the number on the scale where the marker stop. That is all what you should do when you are using a peak flow meter. Okay, so you assume a comfortable position. You take in a deep breath until your lung is full and you hold it. Then you seal your mouth around it. Okay, then you blow as hard. Okay, you blow as hard as you exhale, and then wherever the marking got to, you note it down and then you read it. Okay, all right. So that is it.
Okay, so please, is it that after blowing, will it, let's say it gets to 80, will it stay there for some time, or you have to check
Yes.
immediately? You
Okay.
finish blowing.
Once it rises, it will just be there. Okay, once it rises, it will be there for you to just note the timing. Okay, once it rises, it's going to be there for you to know where the marking was. Okay, all right.
Thank you.
You are welcome. Emmanuel, is it Siame? Please, you can speak. Emmanuel Siame, I see your hand up, Mr. Okay, Mr. Karim. Yes, you can speak.
Okay, so boss, I just want to, contribute to your explanation.
Okay.
Yes, please. I read somewhere that there's a clue for using the peak flow meter and that of the incentive spirometry. So
Okay.
with the peak flow meter, just like you explained, that one you put the map, you assume a comfortable position that's like upright. Then you put the mouthpiece in your mouth, make sure that it's tight or your lips seal around it. Then you exhale. So as you exhale, the ball-like colors, like you can see the red in it, so it will rise to a level and it remains there. But with that of the incentive spirometry, you inhale. That one is to measure the amount of air you inhale. So the clue is that incentive spirometry is for inhalation, and then peak flow meter is for exhalation. Thank you.
Very good. We will talk about it very soon, Clara. It's on my slide, okay? The spirometer, how to use that one too. Okay, but thank you for bringing it out. It's as what you just said, okay? And the one thing about the incentive spirometer, you will get there. Okay, you will get there. All right.
Okay, sir.
So any other question, please? So we are fine on this slide about how to know the marking and what to do at each point in time when you are seeing whether red or yellow or green. Okay, so let's take note. Okay, all right. Now, how do you use an inhaler? This one, Encles will not ask you. Okay, Encles is not going to ask you list the steps in how to use an inhaler. Okay, so yes, a summary. It is very, very long on my screen. Okay, but it's just you should at least know the summary. Okay, it's just something small. So how do you use an inhaler? So you take off the cap. Okay, on my screen you can see the image. The cap is right there. Okay, you take it up. You look inside the mouthpiece and make sure there's nothing in it. Okay, like nothing hindering it, so that when you press the drag, it will come freely. Okay, then you shake the inhaler hard for like 10 to 15 times before you use. Okay, you shake the inhaler hard for like 10 to 15 times before. It helps for the drag to flow as you press it. Okay, then you breathe out all the way. Okay, this is the preparatory phase as you're about to use the drag. You take off the cap, you look inside the mouthpiece, you shake it, you breathe out, then you try to push out as much as air you can. Okay, very good. Then you hold the inhaler with the mouthpiece down. You hold the inhaler with the mouthpiece down. You place your lips around the mouthpiece so that it forms a tight seal. Okay, it forms a tight seal. It should be a bit tight. Okay, then as you start to slowly breathe into your mouth, press down on the inhaler one time. Then you keep breathing in slowly, as deeply as you can. Okay, so the moment you place your mouth around the mouthpiece, you start now trying to inhale in. Then you press the inhaler. Then you keep breathing in slowly, as deeply as you can. Okay, then take the inhaler out of your mouth. If you can, hold your breath as you slowly count 1 to 10. In other words, you hold your breath for at least 10 seconds. Okay, this will let the medication reach deep into your lungs. Are you getting a point? This will let the medication reach deep into your lungs. Okay, pucker your lips and breathe out slowly through your mouth. Okay, and you pucker your lips, you breathe out slowly through your mouth. If you are using inhaled quick relief medicine, wait for at least 1 to 2 minutes before you take your next puff. You do not need to wait between puffs for other medicine. Are you getting that point? So if the drug you are using is a quick release, like a beta agonist, is a bronchodilator, you can just wait like 1 to 2 minutes, okay, before you take your next puff. You don't have to wait wait for too long or between the puff for other medicines to come in. What they mean is that, for example, you are taking other medications with the bronchodilator. Make sure that once you press one or you use the medication one, you can wait for like 1 to 2 minutes and then you add up the next one. Okay, nothing like any medication you are stopping for any medication, nothing. It will not cause any problem. Okay, so you can wait for like 1 to 2 minutes before you take the next one, the next puff. Okay, then after you are done, you put the cap back on the mouthpiece and make sure it is firmly closed. Okay, after using the inhaler, rinse your mouth with water, gargle and then spit. Do not swallow the water. This reduces side effects from the medication. Okay, so do not swallow the medication that comes from, or the water after rinsing your mouth. Do not swallow the water. Just wash your mouth, rinse it, and then spit out. Reduce the side effects of the medication. That is how, and I'm sure we all know the side effects of bronchodilators. We learned it yesterday, right? Tremors, tachycardias are there. Okay, palpitations, they are all some of the side effects of what? Of albuterol and then these bronchodilators. Okay, so to reduce those side effects, don't drink the water. Okay, just rinse your mouth and then spit out just after rinsing your mouth. Okay, so this is how you should use an inhaler. Just know something around it. You shake the bottle or you shake the drug before. Okay, you looking for the looking inside and those things you can ignore. Just shake the medication. Okay, and then make a tight seal of your mouth around the mouthpiece. Then you start inhaling it, then you press. Once you press, hold your breath for like 10 seconds for the medication to sink inside. Okay, then you take off the medication, you rinse your mouth, and then you spit out. That is all. Okay, for inhaler usage. Are you getting a point? Very good. Then we have cleaning an inhaler. This one is an enclosed area. How do you clean an inhaler? Okay, how do you clean an inhaler after using it? Or maybe you want to use or you want to clean an inhaler. So remove one. Remove the canister and the mouthpiece cap. You can see the image on my screen. The canister is the container where the drug is. Okay, the container where the drug is. Okay, so you remove that one and then the mouthpiece cap. So take the canister containing medication and the mouthpiece cap off the plastic actuator. The actuator is the outer body of every inhaler. Okay, the outer body of every inhaler. So you take the canister from it, left with the actuator. Then you raise the actuator. Okay, so hold the actuator under warm water, running for about 30 seconds, ensuring water runs through both ends. Okay, ensuring that water runs through both ends. Then 3, shake off as much water as you can. Okay, from the actuator. You air dry overnight. And then 5, put your inhaler back together before the next use. Okay, put your inhaler back together before the next use. Okay, so this is how you should clean your inhaler. Okay, make sure that you move the canister and then you rinse the actuator. Then you shake off every water Don't let air touch the canister. Okay, so other considerations: never get the canister wet. Okay, never get the canister wet. 2, always use warm water. Okay, always use warm water for the cleaning of the, what do you call it, of the inhaler, right? Then 3, air dry completely. Air dry completely. Then 4, clean the spacer regularly. It should be regularly. Okay, clean the spacer regularly. This is what we should be noting down for cleaning of what? Inhalers. Okay, all right. Any question before we talk about incidence parameters? Incidence parameter. All right. Since there's no question, we can talk about incidence parameter. Good. So your incidence parameter will show how well you are breathing. Using it will help you get back to breathing your best. Okay. It can help you avoid complications by keeping your lungs clear and active after surgery or an illness. Okay. So as Mr. Karim just said, okay, so the incidence parameter also help you to measure the amount of air as you breathe in. You get it. And this can be used for 1, diagnostic purposes, and 2, treatment purposes. Okay, so get it right. Okay, incidence parameter can be used to diagnose and can be used for treatment purposes as well. So how do you use it? 1, sit upright as far upright as you can. Then 2, if you have an incision, apply little pressure to it with a pillow. Okay, because you are going to breathe in. It's like a force. Okay, like a force. So make sure you apply little pressure with a pillow. 3, breathe normally for a few times. Okay, breathe normally for a few times. Now let's get into how to use it. Exhale normally. Close your lips around the mouthpiece. So as you can see the image there, you see the woman closing the lips around the mouthpiece. Okay, so you close your lips around the mouthpiece. Then 5, breathe in slowly and steadily through your mouth until your lungs are full. Are you getting the picture? You breathe in slowly and steadily through your mouth until your lungs are full. The volume indicator will rise to show how much air you breathe in. Okay. So, unlike the peak flow meter, this one, when the volume indicator rise, you bring the marker up to where the indicator rose to. Okay, but then for the peak flow meter, once you exhale, the marking will be there. You don't have to put anything or do anything to the readings. Okay, but for the incidence parameter, when you breathe in, the volume indicator will rise to measure the amount of volume or the volume of air that has been entering the lungs. Okay, the volume indicator will rise, then you bring the marker up to the level at which we are getting. Are you getting the point? Then on the side of your spirometer, move the marker to show the top level that the volume indicator go to, as I said. Then 7, hold your breath until the volume indicator goes down back, okay, to the bottom. Breathe out slowly, then take the mouthpiece out of your mouth. Now let's learn something here. This machine or this device is measuring the amount of air that we breathe in. Now take note. When you breathe in air, the air will fill up the air spaces in your lungs. So your lungs become full. When your lungs becomes full, air does not enter again. Are you getting the point? When you breathe in air and the air fill up the air spaces in your lungs and your lungs become full, air does not enter again. So when you breathe in using the device and the lungs become full and it rise, at that point, your lungs are full. Air will not enter again. So the marker or the volume indicator will begin to drop because there's no air coming again. That is why the volume indicator begins to drop to the bottom. Okay, so this machine, this device, if you are using it, and then after you breathe in, you don't bring the marker to check the level you had or you go to. Mind you, once the lungs are full, the volume indicator will come down. So you're not going to get the correct reading. So always make sure that the moment you breathe in and your lungs are full and air is not entering again, you bring the marker up to check the level before the volume indicator drops. The volume indicator will drop because air is not entering again. The lungs at that point is full. Okay, right, good. Then 8, take a few normal breaths, okay? Or take a few normal breaths for the 8. Then after you are done 9, repeat step 4 to 8, what we just spoke about, okay? Each time you take a breath, try to move the indicator higher than the time before. It simply means that anytime you try to use the device, make sure that you exceed where you go to the previous one, okay? It helps to open up the lungs, especially for treatment purposes. I get the point. This one, especially for treatment purposes, try and then always what exceed the initial limit. It helps to open up the lungs. 10. After you are done a set of 10 breaths, cough. This will help clear the mucus out of your lungs, okay? For treatment purposes, it will help clear the mucus out of your lungs. Then 11, between exercises, put the mouthpiece in a plastic storage bag, okay? Put the mouthpiece in a plastic. So this is what you should know about incentive spirometer, okay? Incentive spirometer. And remind you, you should perform it several times a day, 10 times in an hour, okay? While you are weak, perform at least 10 times in an hour, especially for treatment purposes. Make sure that you are performing it 10 times in an hour. It helps to open up the airway. So this is what you should know about what incentive spirometers, okay? Incentive spirometers, okay? All right. Yes, any question before we talk about the complications of asthma? Okay. Madam Linda, yes.
Yes, Boss Aki, please can you compare it to the peak flow for me again, please?
Okay. So peak flow meter measures. So remember this. When I was explaining the asthma, I said something that in asthma there is constrictions in the airway. Okay, there are constrictions in the airway. So mucus production constrictions. So the amount of air coming is reduced, same as the amount of air going out. And then mind you, because of that, there is a reduced peak expiratory flow rate. Okay, so now if it was taking you like 5 seconds, how do I even put it? If it was taking you a faster rate to breathe in and breathe out, okay, like as we are there, we are breathing in and breathing out, but we are not having any struggle, very, very fast. But because you're having asthma and there is what? There is, what do you call it? There is a constriction, the time it will take for you to exhale the air out prolongs. That is why we say there's a reduced flow rate, expiratory flow rate. Okay, are you getting the point? So we use the peak flow meter to check the amount of air or the volume of air that is being exhaled whilst we are bringing in the house. Okay, we use to measure the amount of air we are going to get when we are exhaling. So the peak flow meter measures the volume of air whilst we exhale, because there's an increase in what expiratory flow rate due to the mucus production causing what a narrowed airway. So the peak flow meter measures the volume of air as we exhale, but the static spirometer actually measures the volume of air as we inhale. Okay, as we inhale. Another difference is that with the peak flow meter, when you exhale, the marking usually becomes, let me say, it stays there, and then you are able to know where you got to. Okay, the peak flow meter, when you exhale, the markings will stay there for you to know where you get to, whether red, yellow, or green. Then you know your percentages. Okay, but the incentive spirometer, mind you, you are breathing in. The moment you breathe in and air enters your lung, the air becomes full. The air becomes full. So at that point, the volume indicator begins to drop because air is not entering again. You stop breathing in. Okay, you stop breathing in. So take note, you stop breathing in. So air will not enter again. So at this point, where you go to when you breathe in, make sure you bring the marker up. Usually the marker is at 0. Before you start the exercise, the marker is at 0. Make sure that once you breathe in and your lungs are full, the mark you go to, bring the marker up to note it. Because once the lungs are full and are not breathing in, the volume indicator begins to drop. Okay, that is the difference between the two of them. Okay, all right. I'm sure you're okay. Right, so someone has stated it in the chat box. So peak flow is out, incentive spirometer is in. Okay, all right, so that is fine. Yeah, any other question? Another question. Another question. All right. So let's talk about the complications of asthma. So as you've been saying, you have what acute what asthma exaggerations, right? Whereby the asthma becomes what severe, okay, and life-threatening. At this point, the patient asthma becomes uncontrolled, okay. At this point, it becomes uncontrolled. You need your dilators as fast as possible to open up the airway. Then we have chronic lung damage. So uncontrolled asthma can lead to chronic lung damage, and then it can even cause respiratory failure. Okay, so you are having asthma, you are not treating the asthma, consistency is there, you are not controlling it. Please, mind you, at a point in time, your lung becomes what damage. It will compensate and compensate and compensate. At the point in time, if you say, Charlie, I'm tired, let me collapse myself. I'm going to get a collapsed lung. Okay. Then 3, status asthmaticus. This is simply a severe form of asthma. So in status asthmaticus, what are we getting? If the patient was having wheezing, here it's a severe wheezing. If the patient was having tachypnea, here the severe tachypnea. So let me say, we can even say that status asthmaticus is similar to the exacerbations, asthma exacerbations. There's a severe form now. Okay, everything has become severe at this point. Okay, then 4, we have pneumonia, and then 5, bronchiolitis. Pneumonia because there's a mucus production. Mucus production can begin to cause inflammations and infections in the lungs and get pneumonia, and there's bronchiolitis as well. Don't forget, the airways are being constricted, mucus production. And then the smaller airways, we have the bronchioles, okay? So if they become inflamed, you can get bronchiolitis. So this brings us to the end of asthma, okay? This is actually the end of asthma. How many times should a client use peak flow meter in a day? Okay, peak flow meter, as I said, is being used to record a personal best within a period of what? How do you put it? 2 to 3 weeks. Usually it's 2 or 3 weeks, okay. But when it comes to the number of times you use within a day, it varies, okay. It varies, okay. But then make sure that you are doing it often so that you get your personal best. Then you compare it with what others. When your asthma is under control, now you can start using the peak flow meter, okay. You can start using the peak flow meter to help with what? To help with the action plan, so that anytime you are there, it should be used often, okay? So that anytime you are there, you know that, okay, I'm at yellow. I will need what? A short-acting beta agonist to open up my area to prevent my asthma from worsening, okay? So that is something you should take note of, right? So it is used often, several times a day, so that, I mean, it can help you note or track whether your asthma is under control or is getting worse, okay? All right. What again? I see here. Okay. So multiple times. You can use multiple times. Okay. All right. A day. All right. So someone is asking that, sir, please do asthmatics end up having a barrel chest? I think I explained this, right? I explained this, that it's going to be hyperinflation on their X-ray as well. Because there's mucus production. In asthma, there's mucus production. It will block the airway. Though in COPD we have what an elastic what air sacs. We have an elastic air sacs preventing the air from coming out. It is not common in asthma anyway. But then, because there is a narrow airway, the amount of air coming out is limited. So the air can also accumulate and it can cause hyperinflation. Okay. So if you don't treat the patient, you don't give the bronchodilators and the rest, it can begin to swell up with the chest, and then it can end up like that. Okay. All right. Please, how long do you have to wait before you do another round of the parameter? There is no specific time, It should be used like 10 times in an hour. Okay. It should be used like 10 times in an hour. Okay. It should be like 10 times. While you are awake, try and use it more while you are awake. Okay. Try and use it more while you are awake. There's no specific time, like wait this and wait that. Okay. All right. So let's take note of that. Mr. UCVS.
Okay. Boss, okay.
Yes.
Is there a complication?
You said what?
I asked if death is considered as a complication and then can be added here.
Hey, Mr. You see, death is a
I'm
complication.
asking.
Death is a complication to every condition.
So okay, so that means that we can have it here, right?
Yes, death is a
Well,
complication to every condition. Okay. If you have any condition and you don't manage it, you can die. Okay, you can die. All right.
Just a little thing. The ipratropium, it
Mhm.
comes in a capsule. And the capsule, we are not to swallow it. You educate the patient not to swallow it. And then
Okay.
the metered dose inhalers, we have
Mhm.
some that comes in powder. And then the powdered one too, you are not to shake it. And when you are inhaling it too, you do it very fast, deep and fast. And you hold your breath for like 5 to 10 minutes. But the other type, the liquid, I don't know, it's liquid. That one, you do it slowly. But then the powdered one, it has to be fast. Thank you.
Very good. Okay. Thank you for that addition. Okay. All right. That's perfect. All right. So please, any other question?
And Nanekia, the question goes to her. So if we don't swallow, what do we do? You get the question?
Yeah, telling me. So we inhale it. So it comes, it has a special, is it a contain, something that they use. So you have to put the capsule inside let me say the machine. Then that one you don't have to open it. You cover it and then you inhale it. When you cover it, it will open by itself.
Yes, yes. We only heal them. Okay. The powder and the rest, it is still being healed. Okay. So let's take note. All right. Yes. Any other question?
But okay,
Yes.
please, in the absence of this terror, I can go for the tropium, right? Aside the other medications.
Oh, this is too pathetic.
Yes. You can. Okay. You can. You can give them. Okay. You can give them. Right. You can use just that usually the short acting works better. Okay. But don't forget the hypertropium can also be used. Okay. Okay.
Yeah.
The hypertropium can also be used probably when the patient is reacting to the bronchodilators. Okay. The short acting ones. You can use the anticholinergics. And then that is why the anticholinergics too, we have two. We have the short acting and the long. We have the hypertropium and the tiotropium. So in that instance, we give the hypertropium. Okay. All right. So that is what you should take into. All right. So let's solve some questions on my slide. Okay. Let's test our knowledge on what we've learned so far on asthma. Okay. All right. So let's move. Who do the honors to read? Who do has the honors to read?
Sakiari.
Okay, please read, madam.
Okay, so the nurse is preparing to teach a client who is newly diagnosed with asthma on how to prevent asthma triggers. Which triggers should the nurse include in the teaching plan? Select all that apply. A, cigarette smoke. B, mattress cover. C, indoor pets. D, stuffed animals. And then E, tiled floors in the house.
Okay, so let's put the answer.
But
I
I
see.
keep, I'll go for A, C, and D. There's cigarette smoke. It's not good for them because when they inhale it, it can trigger the asthma attack. And then the indoor pets and stuffed animal, because of their hair, when they inhale it too, it can trigger the asthma attack.
Okay. All right. Perfect. All right. So let's see the rationale. The answer is ACD. Okay. Asthma triggers include cigarette smoke, indoor pets, stuffed animals. Carpets rather will cause the trigger, not tiled floors. So take note. Okay. It is rather carpet. You know, carpets can harbor dust. So carpets, not tiled floors, should be avoided as they can trigger asthma. The mattress covers should be used to decrease dust mites, which is a trigger for asthma. Okay. Perfect. Next question.
The nurse is examining a client newly diagnosed with asthma. Which pathological characteristics should the nurse expect in this client during physical examination? A, dead space. B, air trapping. C, respiratory reason. And D, increased lungs volume.
This one here, the answer is C, right? Pathophysiology. Pathophysiology, we explained it, right?
Yeah.
Yeah, so the air is trying to force it out, giving us that wheezing sound, right? Because of the bronchoconstrictions and the mucus production. Okay. All right. So the answer is C. So on physical examination, there is respiratory wheezing. This is often described as high-pitched and musical, and there is prolonged or prolongation of what? Respiratory phase of the respiratory cycle. Lung volume is decreased. Lung volumes, oh please. Lungs volumes is decreased. Air trapping and dead space occur in emphysema, okay? Not common in asthma, okay? As I said, not really common in asthma. Okay, all right. Next question, please, you can read.
Okay, so the
Hello,
next
sir. Sir, please, the question one. Apart from the tile floor, which one was also not applicable? I didn't get that one.
It is the distance.
mattress cover.
The mattress covers.
The mattress.
Okay.
Oh, okay.
It
Thank
protects
you.
that mind. Okay. All right. Please, you can read. Let's go ahead.
Okay, so the nurse is teaching a client with asthma about peak flow meter use. Which action by the nurse indicate that the teaching was successful? A, the client anticipates using Mantilucas for reading in the red zones. A. B, the client exhales slowly into the mouthpiece to obtain a reading. C, the client uses the albuterol inhaler for peak flow readings in the yellow zone. No. D, the client plans to contact the healthcare provider when the readings are in the green zone.
Yes. What are we picking?
Hey, Basaki. So this one, I will use the elimination method. So the D, I will cancel the D out because the green zone, the patient is stable. And then the use of the albuterol, the yellow zone 2, the patient is to use his normal bronchodilators. So the albuterol is used in the emergency, the red. And then the A2, the client anticipates using Mantilucas for reading in the red zone. So you made mention that we don't use it in the acute phase. So the B, even though I'm not sure,
Mantilucas for readings in red zone. I'm listening.
I'm not really sure. So that one.
So what did you pick?
Out.
What are you picking?
I'm picking the B because that one, the other, this one is wrong. So I'll go for the B. Thank you.
All right, let's analyze the question. Okay, let's analyze the question. So by elimination, option D is out. The green is okay. Patient does not need any intervention. So no need to call the physician, right? Perfect. D is out. A, I said it emphatically that you don't use Montelukast in emergencies, right? I said it, okay? Despite the fact that they block the leukotriene that causes the constrictions, you don't use it in acute settings. So the red, in fact, the red, you don't need that's like this. You need emergency intubations and the rest, okay? Good. So now we are left with B and then C. Now let's analyze the question very, very well. Okay. Very good.
Mosaki,
Yes.
the thing too, he said they should do it fast. It should be deep. It's like fast. They should, So the B2 is kind of wrong.
So the thing is that once you get to the, I think I kept saying this. When you take and there's yellow zone means that the airway is getting worse. You need a bronchodilator to open the airway to prevent you from going into red. Okay. Are you getting the point? Okay. You need a bronchodilator to open the airway into what? Into red. Yeah, the answer is C. Okay. The answer is C. It's no B. Okay. All right. So let's see the rationale. Readings in the yellow zone indicate a decrease in peak flow. That should be treated with short-acting beta adrenergic medication such as albuterol. Okay. So let's just get that understanding. Once you are the yellow, the airway compromise is getting worse. The asthma is getting worse. You need something to open it as fast as possible. Okay. Readings in the green zone indicate good asthma control. So there is no need to contact the healthcare provider. The client should be taught to exhale quickly and forcefully through the peak flow meter mouthpiece to obtain the readings, not slowly. Okay. Readings in the red zone do not indicate good peak flow, and the client should take a fast-acting bronchodilator and call the health provider for further instructions. Montelukast is not indicated for acute attacks, but rather used in maintenance or therapies. Okay. Are we getting it? So please, let's take note of it. Okay. Let's take note of it. Once we see red, give maybe an albuterol, okay, a short acting to prevent the asthma from worsening. Okay. All right. Yes,
Okay.
next question.
A client with a history of asthma presents with bradycardia and severe wheezing. Which action should be the next priority? A. Preparing to assist with intubation and mechanical ventilation. B. Auscultating the lungs. C. Encourage the client to cough and breathe deeply. Then D. Administering an intravenous corticosteroid.
Yeah, so what are you picking? A, B, A, B, A, B, A, B, A, B, A, B. And then you're quiet.
Yeah, I'm quiet because I'm stuck between the A and B. So you made mention that when they come, the first thing we should do is to auscultate the lungs. And now they are talking about priority. Okay,
And
so
the
there's
person is
severe
pay attention. I'm listening. Please talk.
there's severe bradycardia and severe wheezing. So maybe I'll go for the A.
Yes. So no, when you are stuck between two options on your end list, this is how you analyze the question, how you did it. How did it? Okay. When you are stuck, go back and read the question again. You realize that the answer is there. The question say the patient have severe with severe wheezing. Listen, wheezing which is severe. Imagine wheezing which has become severe. The patient is having a total collapse of the airway. If you don't intervene, things will get worse. Okay, so you just need an intubation. So the answer is A.
Yeah, but Aki, so there's one tip. They said that in emergency you don't assess, you intervene. So it's like this patient is an emergency patient.
Exactly. right.
Yes, so you
The
have to.
client clinical manifestation indicates impending respiratory failure, right? And immediate action is required. So the nurse should notify the health provider. The nurse should prepare to assess intubation, mechanical ventilation. After notifying the health provider, having corticosteroids requires several hours before having any effect in respiratory system. Auscultation, coughing, and deep breathing will not help this client at this moment. Okay. Now, next question. Maybe
Next
these are last.
question.
Yes.
Oh, a client who is experiencing an acute asthma attack is brought to the emergency department. Which action should the nurse take first? A. Administer
But
and inhale
someone
corticosteroid.
asked a question. No, someone asked a question.
Where?
The lady.
Where? Please, who is asking the
No.
question?
Hello.
Yes.
The previous question, I heard someone saying that in the question, as compared to assessment versus implementation. So you do assessment before this thing, the implementation. I heard someone ask a question like that.
I was saying that I came across something and they said in emergency situation, you don't assess, you intervene. That's what I said.
Mr. Isiba, are you okay?
Yeah.
Okay.
Okay.
I didn't get her question.
Okay.
You-
So let's finish with this question.
Okay, a client who is experiencing an acute asthma attack is brought to the emergency department. Which action should the nurse take first? A. Administer and inhale corticosteroid. B. Obtain a peak flow meter reading. C. Auscultate the lungs. And then D. Determine when the shortness of breath began.
Yes. So what are you picking? I see people picking. So now people are tossed between C and A.
Yes. So you
So
go for the.
let's see the question again. Right. A client with. But why are you even picking A? A client is experiencing an acute asthmatic attack. Go to the ER. Which action should the nurse take first? Assessment to nursing care plan. And even if you are going to need a drug in an acute attack, it's not corticosteroid. It should be a bronchodilator. So why are you picking the A? If you are going to need any drug in acute asthma attack, it should even be a bronchodilator. Please take note. In acute asthmatic attack, the dilators come before the steroids. Okay, the dilators come before the steroids. So the answer here is C. And then you've not even assessed the patient. Okay, you've not assessed the patient. Now, do you know? Let me go back to this question. The reason why the answer or the priority was not auscultating was because assessment was done in the question. We saw that the patient was having severe wheezing and severe bradycardia. Assessment was already done. Okay, so we go ahead and intubate. Are you getting the point? Assessment was done in the question. But here, you don't see assessment in the question. The person was just an acute attack. Nothing has been done. Okay, so you need to what? Assess the patient what? First. Okay, all right. So this one gives the answer as C. Assessment of the client lungs will help determine what? Will help determine how effective the client is ventilating and whether rapid intubation may be necessary. The length of time the attack has persisted is not important as determining the current status or the current status. During an acute attack, are unable to use the peak flow meter. Medication administration should be done following assessment. Okay, medication administration should be done following assessment. Hey, I have one last question.
Okay. So the nurse is evaluating the effectiveness of a therapy for a client. Okay. So the nurse is Mr. Idrisu. The nurse is evaluating the effectiveness of the therapy for a client following a treatment for an asthma attack. Which assessment finding is the best indicator that the therapy has been effective?
Don't get strict, though. Read the question very, very well. Don't get strict. All right, let's move on.
A, no reason. B, capillary rate field is 2 seconds. C, respiratory rate is 18 cycles per minute. And then the D is oxygen saturation is 96%.
What's the answer? I see A, D, A, D. Please, who is speaking C? Normal respiratory level 12 to 20. Why are you picking C? It is normal. But we are looking for the best indicator, right? Okay. Okay, sorry. You can pick the C.
Yeah, I'll go for A. Yes.
Oh, from I was A, right? Who is picking A? Okay. So let's analyze.
Kia is speaking A.
Yes, because sometimes the patients they will come in. Sometimes you check they will tell you they are in distress, and you check their saturation and it's normal, and everything will be normal. So I'm thinking that the answer is A. If there's no reason, then it means the therapy is effective.
And so also, it can be that they might be wheezes, but then saturation would be at the normal range. So I'm for it.
We are for A. And then someone is saying that if wheezing stop, problem will. Okay.
The reason when
Brother,
you don't intervene and stop, or wheezing stop, that's when there's problem. But if you intervene and wheezing is not there, I don't think it's a problem because wheezing is a cardinal asthma. Thank you.
Okay, Mr. Yusuf, yes, you can speak.
I learned that no reason to can mean that the patient is not into severe distress, like silence chest. That means, yeah, so that means that the patient is not even having that energy to pass the air through that fluid.
Your answer is A.
C. My answer is C.
Okay, your answer is C. Okay.
Yes, my answer is C.
Okay.
But boss, say the question is saying that the nurse is evaluating the effectiveness of a therapy for a client following treatment for an asthma. So it was established that there was an asthma, and now we want to evaluate the effectiveness of the treatment that we have offered. So if you are no more listening to any online transportation, there are no more reasons, then the treatment is effective.
Yes. Okay, so you are going for that thing. All right. So let's understand this. Okay. The answer is D. But let's understand something. Okay. All right. So let's rule out B and C. Okay. For that one, we can't use that one as a clinical indicator. Okay. For asthma. Okay. One thing is that a patient with asthma, the clear problem, okay, is respiration. There is a blockage of the airway. When you look at the pathophysiology of asthma, smooth muscles are blocked, are constricted. There is mucus production preventing air from coming in. So even if the patient breathes in, there's limited amount of air entering the lungs. So there's going to be a reduction in the oxygen in the patient's blood saturation level. It is going to drop. That is the main problem. The wheezing is just as a result of the narrowing. Okay, the wheezing came because there was a narrowing. Are you getting the point? The air is trying to force itself through the airway. That is why you are getting the wheezing. But the clinical problem is that the air is not coming in, it's not going out properly. So the patient oxygen level will have a problem. So that is the key sign here when it comes to, or let me say, the key indicator that the patient was wheezing or what has been well treated. Because when we are dealing with a respiratory issue, or let me say an oxygenation issue, there's limited amount of oxygen going into the lungs for it to be used by the body, and then limited amount of carbon dioxide coming out. Okay, so even partial pressure of oxygen is being reduced. Okay, so if wheezing is good anyway, but then here we have to focus on oxygenation here, because that is the real problem of the patient with asthma. The airways are blocked. The wheezing came just because the patient was trying to force the air, or the body was trying to force the air through the airways. Are you getting the point? So that is the best indicator, okay, to diagnose the patient after evaluating the patient with what? Your treatment. Are you getting the point? Very good. So that is, so the problem actually is a respiration problem, a saturation levels. Okay, a saturation levels. So let's see the rationale if we are right. So the answer is D. Okay. So the goal of treatment, Madam Genevieve, the goal of treatment for an asthmatic attack is to keep the oxygen saturation greater than 90. Okay. So the reading of 96 indicates that therapy has been effective. No wheezing head on auscultation does not indicate good ventilation or oxygenation. As I said, no, the no wheezing you hear simply means that the air going through the airways are not enough. It simply means that there's poor oxygenation. That is why the patient is trying to force the air, hence getting the wheezing. Okay, so if nothing was wrong with the patient oxygenation, why would the patient's body force the air to get the wheezing? Okay, so the real problem is to deal with the oxygenation. I getting the point. Good. The respiratory rate and capillary refill time appear within normal limits. However, this data can also occur when a client is too fatigued to continue with the increased work of breathing that is required in an asthmatic attack. So the answer was the saturation level. Okay. All right.